Good morning, everyone. So today we are going to revise the pelvic diaphragm and uterus. So already we have revised so many times. So today we are going to revise only pelvic diaphragm and uterus. Okay. So what are the today's objectives? What is this pelvic diaphragm? So diaphragm means what kind of diaphragm it is. It is a musculo-fibrous diaphragm. And why it is known as diaphragm and how come it is important for pelvis. So these are the component parts and functions we'll discuss under the pelvic diaphragm. Then uterus. So what are the relations, parts, various supports. So we have to know, well, means you should know the details about the supports of uterus. So what are those supports? And the structure, blood supply, nerve supply, and clinical importance. So these are the objectives we are going to discuss today. So coming to the pelvic diaphragm. So what I told, pelvic diaphragm is a fibromuscular sheath and where it is present. So the name given pelvic diaphragm, so it should be present in the pelvis. So what is the exact location? How can you define this pelvic diaphragm? See, in this picture you can identify a gutter-shaped structure like a sheet. So what is that sheet? Mainly made up of muscle. Okay, and this muscle superiorly and inferiorly covered by fascia. Okay, so it is a fibromuscular sheet. And what kind of shape? Gutter shape. And what is the location? It is just present in the, means in the pelvis, just above the perineum. So what is the meaning here? This is a structure which separates the pelvic cavity from that of perineum. And what is perineum? The perineum means the structures, whatever structures, muscles, fascia, and whatever, the structures occupy in the pelvic outlet. So those structures are just lies beyond this pelvic diaphragm. Okay, so it is a gutter-shaped thin sheet of muscular partition. You should not write muscular; it's a fibromuscular partition separating the pelvic cavity from the perineum. So it lies at the level of, what is that level? Pelvic outlet. But morphologically, see, this is pelvic diaphragm is migrated from the pelvic inlet towards the outlet. And why it is migrated? Due to the erect posture. So in the evolution, what happened? Due to erect posture, the pelvic inlet, pelvic diaphragm, this muscle is shifted gradually caudally towards the pelvic outlet. So it lies at the level of pelvic outlet just above the perineum. That's why it is a partition between the pelvic cavity and perineum. Then what are the component parts? As I told, it is a fibromuscular. So what is that muscle? Here, two muscles are present because the two muscles lies in the two different planes, not a single plane. So we have two sets of muscles, means pair of muscles, right and left sides. What are these two muscles? Levator ani and coccygeus. But morphologically, it is a single entity. What is that? Levator ani and coccygeus. It forms a single entity developmentally. Morphologically means developmentally it is a single sheet of muscle. Okay. Then what are the different parts of this muscle? See, again the levator ani is consisting of, from before backwards, the pubo-coccygeus fibers, then ilio-coccygeus fibers, and the most posterior fibers are ischio-coccygeus fibers. So what are these fibers? From before backwards, levator ani is again consisting of three parts. Pubo-coccygeus, as they are extending from the pubis, means from anterior pelvic wall to the posterior pelvic wall. So pubo-coccygeus. Then beyond that, what are the fibers? Ilio-coccygeus. And the posterior fibers are comprising ischio-coccygeus. Then the most posterior component of the pelvic diaphragm is coccygeus. Here, coccygeus is nothing but ischio-coccygeus. That's why I told, morphologically, this pelvic diaphragm has a single entity. But on structure, means by cross inspection, we can see this pelvic diaphragm under different structure, different names. So what are those names? Pubo-coccygeus, ilio-coccygeus, and ischio-coccygeus. The ischio-coccygeus is nothing but coccygeus muscle. Okay, and what are the two fascia? This superior surface is covered by this pelvic fascia. Okay, this surface is covered by the superior fascia, whereas the inferior surface is covered by fascia, means fascia covering the levator and neck. Then openings of the pelvic diaphragm. See, if you observe the entire pelvic diaphragm, we have usually two openings, normally, but abnormally, there is one more opening, that is the hiatus of Schwabe. So what are these openings? If you find out, this gutter-shaped muscle forms an anterior deficiency. Have you appreciated here? Between the two sets of pubococcygeus fibers. You see, the anterior-most fibers of either side merges and thereby forming a U-shaped gap. So what is this? Is a hiatus urogenitalis. And why it is known as hiatus urogenitalis? As it is giving passage for the urogenital structures. So in case of males, the urethra will pass through this space, whereas in females, behind the urethra, one more structure. What is that? Vagina. So these two structures are passing through this urogenital hiatus. That's why the name given, urogenital hiatus. Then what is hiatus rectalis? If you see, there is a centrally placed a circular opening where it gives passage for the rectum. So this circular gap or ring is exactly lies at the level of anorectal junction. So this hiatus is known as hiatus rectalis. Then hiatus of Schwabe. So to know the hiatus of Schwabe, we should know the details of the origin of this levator ani. So what is the origin of levator ani? See, the levator ani takes origin from the inner surface of the body of the pubis. See, this is the body of the pubis. So inner surface of the body of the pubis. Then along a line, see, along a line from this body of the pubis. So the line represents here a iliopubic eminence. Here you see, this is a pectineal line. So beyond that, you see, this is a fibrous thickening where the pelvic fascia merges with the obturator fascia. So where it forms the tendinous arch, which is otherwise called white line. Okay, so arcus tendinous. So if you see the origin of the pelvic diaphragm, from before backwards, what is the origin? Inner surface of the body of the pubis, then arcus tendinous, then most posteriorly, if you observe, the inner surface of the ischial spine. So this is a continuous origin of the levator ani muscle. So if the levator ani fails to take origin from this fascia covering the obturator internus, means what I told, the arcus tendinous is formed by the fusion between the pelvic fascia and the obturator fascia. So if the levator ani fails to take origin from here, there is a opening. So what is that opening called? Hiatus of Schwabe. If it is persists, what happened? There may be a chance of herniation of pelvic viscera into the corresponding ischiorectal fossa, because through which the pelvic fascia, means pelvic cavity, is communicating with that corresponding ischiorectal fossa. So there may be chance of the herniation of pelvic viscera into the ischiorectal fossa. So that is the hiatus of Schwabe. So what I told, what are the parts of pelvic diaphragm? Pubococcygeus. So first we will discuss about the pubococcygeus. See, the pubococcygeus, if you identify here, it presents two sets of fibers, anterior fibers and posterior fibers. If you trace the most posterior fibers, you see they are passing backwards, downwards and towards the sacrum. The lowest piece of the sacrum and the upper two pieces of the coccyx. So the most posterior fibers gets inserted to the sacrum, lowest part of the sacrum and coccyx. So here this is the pubococcygeus, most posterior fibers. If you identify the middle fibers of pubococcygeus. You see here, middle fibers of pubococcygeus. They are forming a U-shaped loop around the rectus hiatus. Means what is there at the rectus hiatus? Anorectal junction. So the middle fibers of pubococcygeus forms a U-shaped sling around the anorectal junction and continues with the opposite fibers. So thereby it forms a U-shaped sling. So which is known as puborectal sling. What is that? Puborectal sling. And the most anterior fibers of pubococcygeus, you see, they are just surrounding the prostate in case of males, whereas in female, it forms a constrictor around the vagina. So where it forms levator prostate in case of males, whereas levator means it is not a levator here, it forms a thick band in case of females. So it is otherwise called constrictor around the vagina. So constrictor vaginae or sphincter vaginae. So this is very, very important in case of females because it supports the uterus. So it constricts the vaginal opening, so thereby it prevents the prolapse of the uterus. Okay. Whereas puboprostate means levator prostate in case of males, it is levating the prostate gland. So this way the pubococcygeus presents three sets of fibers: anterior fibers, middle fibers, and most posterior fibers. Okay, and the most posterior fibers are on its way. They are attached along the midline. So in a fibrous band means from two sides the muscle fibers are inserted at the midline. So thereby it forms a fibrous structure which is called anococcygeal raphe. Okay, this is anococcygeal raphe. Then coming to the iliococcygeus. So iliococcygeus takes origin from this posterior part of the white line and the inner surface of the ischial spine. So these fibers are going to insert the coccyx, iliococcygeus. Then the ischio-coccygeus, otherwise called coccygeus, which takes origin from the pelvic surface of the ischial spine, then inserted to the coccyx. Here you see the most posterior fibers of the coccygeus is degenerated. And here you can find out a ligament between the ischial spine and the sacrum. What is that ligament? Sacrospinous ligament. So the sacrospinous ligament is nothing but the most posterior degenerated part of the coccygeus. Right? So normally you see the pelvic diaphragm is very, very important for supporting the pelvic viscera from below. Means it props the pelvic viscera from the below. So that function is solely, means it is mainly provided by the pubococcygeus. Why? Because the ischio-coccygeus mostly it is degenerated in the form of ligament. Even the iliococcygeus also degenerated. So usually this pubococcygeus has taken this function, means that role in the support of pelvic viscera mainly contributed by this pubococcygeus. So we should know the details about this pubococcygeus. So anterior fibers forms the levator prostate in male, whereas in females it forms the sphincter vaginae. Whereas the middle fibers forming the puborectal sling. This is very, very important, puborectal sling. So what is the function? I will discuss in the next slide. Then the most posterior fibers. What are these fibers? Pubococcygeus. Posterior fibers are most posterior fibers are forming, which are inserted to the anococcygeal raphe. Okay. Now coming to the levator plate means the entire, all the components of the levator pelvic diaphragm which forms the levator plate means the muscle along with the fascia. So the shelf on which what happens, the pelvic organs rest and is horizontal when the body is in standing position. Then supports the rectum and upper 2/3 of the vagina above it. The weakness of levator ana may loosen the sling behind the anorectum. So what is the sling behind the anorectum? Puborectal sling, or otherwise called puborectalis. And this cause the levator plate to sag. It will be sag. So what happened? Opening the urogenital hiatus, then allowing pelvic organs prolapse. So what happened? Weakness of the levator ani, nothing but pelvic diaphragm. So opens the urogenital hiatus, then allows the pelvic organ prolapse. The urogenital diaphragm. What is this? Another fibromuscular tissue. It closes the levator hiatus. So what is this levator hiatus? Urogenital hiatus. So the urogenital hiatus is closed by urogenital diaphragm and which supports the distal vagina. What I told? Anteromost fibers of pubococcygeus forms the sphincter around the vagina. So it forms a sphincter at the distal vagina. Then provides structural support for the distal urethra also. Okay. Then what are the functions of the pelvic diaphragm? See, first, foremost important function is nothing but pelvic viscera is supported by this pelvic diaphragm. Then levator prostate, anterior fibers. So what is levator prostate? You should mention only anterior fibers of the pubococcygeus. Then sphincter vaginae, the anterior fibers of the pubococcygeus. Then during defecation, this puborectal sling will be relaxes, whereas puboanal fibers are elevate the anus. Here you see, during defecation, after defecation or paturation, what happened? This puborectal sling relaxes. So the coccyx is displaced backwards. So again, it should be retained in its position. So how it is retained in position? By means of a single muscle, that is that ischio-coccygeus. Why? Because the ischio-coccygeus pulls the coccyx forwards. After the act of micturition or paturation, the coccyx is tilts forwards, means retain its position by means of contraction of the ischio-coccygeus muscle. In addition, see, in paturation, fetal head is rest on the puborectal sling. And this puborectal sling tilts the fetal head forward towards the birth canal. Then during maturation, the pubococcygeal muscle is relaxes. Then bladder neck descends to stimulate the detrusor muscle. So what happened? In increased abdominal pressure, the pubococcygeus is relaxes. Then what happened? The urinary bladder is descent. So by this descent, the detrusor muscle is initiated to contract. So thereby it leads to void the urine. Means maturation. Okay. So these are the various functions of the pelvic diaphragm. So what is pelvic diaphragm? It is a gutter-shaped fibromuscular partition between the pelvic cavity above, perineum below. So what is the plane? It lies at the level of pelvic outlet. Clear? Then it has, on morphologically, it has two structures. Cross structure, two. But morphologically simple. That is the levator ani and coccygeus. And again the levator ani has three parts: pubococcygeus, iliococcygeus, and ischio-coccygeus. So, though we are giving the third, the ischio-coccygeus, but it represents the coccygeus itself. So, ischio-coccygeus is nothing but coccygeus muscle. Then coming to the uterus. So, uterus or womb, where it is present, it's a part of female reproductive tract that nurtures and protects the fetus during pregnancy. It's a function of this uterus. So, where it nurtures and protects. Then location in the pelvis, and where it, in the pelvis, where it is present, anterior to the rectum and posterior superior to the bladder. So, here by its location, how it is present means what is the actual normal position of the uterus and how the position of the uterus is maintained. So for which we should know the different parts, everything. Then during a woman's reproductive years, so means in a non-pregnant state, the size of uterus is about 3 inches long and 2 inches wide. See, usually the size of the uterus, 3 inches in length, means 37.5 centimeters length. Then 2 inches width, and one inch thickness. Whereas in children, the length is, I will discuss in the next slide. So what is that? Length 3 inches, width is 2 inches and thickness is 1 inch. So the position of the uterus, you see in children, it lies above the pelvic inlet. Whereas at the age of puberty, means at the time of puberty, the fundus of the uterus lies below the pelvic inlet. Below the pelvic inlet. In pregnancy, you see, if you identify, by the 4th month, you see the uterus extends above this pubic symphysis, means above the pubic symphysis. Then by the 5th month, it lies about, means the level between the umbilicus and the pubic symphysis. And 6th month, pubic symphysis. Like that, it extends up to the xiphisternum by month of 8th. Afterwards, by the descent of fetal head, in order to, means accommodated in the pelvis, what happened? It descends gradually. Okay, so it gradually descends from the sternal angle, means that is the xiphi, not sternal angle, xiphisternum. Okay, so gradually the uterus will grow progressively, then it extends by the level. You see, from the symphysis, maintain, this is the pubic symphysis, so above the pubic symphysis to the xiphisternum. Then what are the relations of the uterus? You see in this picture, what are the relations? Anteriorly, it is related to the, this is urinary bladder. So anteriorly, the uterus is related to the peritoneal fold, that is the uterovesical fold. Then it lies on the superior surface of the urinary bladder. So the most of the uterus, means that is body, it lies on the superior surface of the urinary bladder. Whereas supravaginal part of cervix is related to the posterior surface or base of the urinary bladder. Whereas posteriorly, it is related to the peritoneal fold. What is that? Recto-uterine pouch. This is a recto-uterine fold of peritoneum. Presents a sac pouch. What is that? Recto-uterine pouch. So where it is related to the ileum and somewhat above the sigmoid column. So posteriorly it is related here with these coils of the ileum, whereas anteriorly it is related with the urinary bladder. Whereas neither side it is related with the peritoneal fold, that is the broad ligament, and along the sides we have a tortuous uterine artery. So these are the very important relations of this uterus. Then what is the normal position? See, the normal position is, we can consider under anteversion and anteflexion. So what is meant by anteversion? See, the long axis of the cervix makes an angle with the long axis of the vagina, where it is about 90 degrees. So it is anteversion. Then what is meant by anteflexion? If you see, the long axis of the body makes an angle with the long axis of the cervix. So what is the meaning here? The long means the body of the uterus bends forwards upon the upper surface of the urinary bladder by making an angle with the axis of the cervix. So it is about the 170 degrees. So this is a normal position of the uterus. So we can consider as anteversion and anteflexion. So in this position, the uterus is kept in position by means of other structures also. So we will discuss all these structures in the next slides. So this is a normal position. So it is means in relation to the bladder in front and behind rectum. So what is the state of this bladder and rectum? Accordingly, we will see this position of the uterus. Then what are the other various positions of the uterus? So this is anteverted and anteversion with anteflexion. So this is normal position of the uterus. Okay, and sometimes you see it is retroverted. This is a mid position, means antiverted, anti-flexed but retroverted. Okay, see here this is retroverted, means backward rotation of the body. Antiversion means forward rotation, whereas retroverted means backward rotation. So by the backward rotation, what happened? It rests on the rectum. Then retroversion, retroversion is associated with retroflexion, means the angulation between the cervix and body is a backward flexion, whereas forward flexion between the body and cervix is anti-flexion. So these are the various other positions of the uterus. Then what are the parts of the uterus? See the parts of the uterus. The most upper part of the uterus is nothing but body. Then the lower 1/3 is cervix. So the main two parts of the uterus are upper 2/3 is body, whereas lower 1/3 is cervix. So this ratio, body and cervix ratio in adults 2:1, whereas in children it is 1:2 ratio. Means the body is 1, whereas the length of the cervix is double than that of the body. So by the time of puberty, what happens? It will reach us to the adult size. So in the adult, what is the ratio between the body and cervix? 2:1. And the most upper part means that upper end of the body is forming fundus. So this is the upper end of the fundus. Then at the two angles, you see these are the two angles of the uterus, otherwise called cornua, where the uterine tube piercing the musculature of the uterus. So this is the, see, within the uterine wall, the part of the uterine tube you can identify. So what is that? Intramural part. So this uterine tube where it piercing the uterus, which is known as cornua or angle of the uterus. So how many angles? Two angles of the uterus. Then this is the body, then cervix. See, at the junction between the body and cervix, there is a constriction, which is known as isthmus of the uterus. So what is this? Isthmus of the uterus, where there is a constriction between the body and cervix. Now coming to the cavity. See, this is the uterine cavity. If you take a section, coronal section, the cavity is in triangular shape. If you take this section sagittally, you will get a vertical slit. Why? Because anteroposteriorly it is compressed. The uterine body is anteroposteriorly compressed. So you will get on sagittal section a vertical slit. Whereas in coronal section you will get a triangular cavity slit. Right? So this triangular slit on either side in the upper part continues with the uterine tubes, whereas below it is continuous with the cervical canal. So where the uterine cavity communicates with the cervical canal, which is known as internal os. See, this is the internal os of the cervix. Whereas the cervix is communicates with the vaginal cavity. So where it forms an os or opening, which is known as external os. So in between you can identify what is the shape of the cervical canal cavity. It is a spindle shape. Why? Because towards the openings it is narrow. At the middle it is somewhat wider. So a spindle shaped slit we can see in the cervical canal. Okay. And see, this uterine cavity doesn't extend into the fundus. And all sides the fundus is convex. Whereas on the lateral borders of the uterus are rounded. Right? You see? On the posterior side and anterior side, it is convex. So, the uterine cavity doesn't extend into the fundus. So, what is fundus? Above the openings of uterine tube, the uppermost, otherwise called the base of the uterus, is nothing but fundus. See the cervical canal. If you see in nulliparous, it is not given, but so in such case the cervical canal is, that is the external os opening. Here it forms a circular opening. Whereas in multiparous, who are given more, means more than 2 children, birth to more than 2 children, So in such people, you see the cervix, the external os of the cervical canal is gives a transverse slit presenting anterior and posterior lips. So from conception, the function of the cervix. So what is the main function of the cervix? The cervix is the important structure to retain and protect the growing conceptus. Okay, but towards the term, the cervix must soften and shorten, thereby dilates to allow for the passage of the fetus. If just imagine if the cervix is structurally weak, what happens? It may open too early. So it leads to preterm birth. So in order to avoid this preterm birth, the gynecologist must see whether this means what is the position, the state of this os. So the current method of identifying for this os, so what is the transvaginal ultrasound. So we can identify what is the cervical canal, means the mainly these os. So clinicians are able to assess the cervical length, means short cervix is associated with the preterm birth, and the degree of funneling which leads means the internal os has a dilated, how much it is dilated. If you are observe, you see, just compare these two. Here the external and internal os are closed, whereas here you see the internal os is open. Have you identified? So by the transvaginal ultrasound, we can identify these structures. So in order to prevent these preterm births. Now coming to the supports of uterus. So supports of uterus means why we should know the supports of uterus. Because if any deviation from its normal position. So what is the usual position of the uterus? The anteversion and anteflexion. So if any deviation from its position, normal position, it may lead to prolapse. But the prolapse is not normal. So how it is supported? So what are those supporting structures? Means to keep the uterus in position. So these supports are divided into two types. Primary, or these are the chief uh, important supports for this to retain the uterus in position. Then secondary or accessory supports. So what are the primary supports? Muscular. Already in the previous slides, we have discussed about the pelvic diaphragm. So pelvic diaphragm means mostly the pubococcygeus, and the most fibers are very important to keep the uterus in position. Means the outermost fibers forms the sphincter vaginae. Okay, so this sphincter keeps the cervix in position, thereby it not allowing the prolapse of the uterus to the vagina. Okay, then urogenital diaphragm, then perineal body. Perineal body is very important because the perineal body, it supports and maintains the continence of this uterus from below. It gives a well support. Okay, then visceral structures. So what are the viscera which are helping to keep, means to keep the uterus in position? Urinary bladder, vagina, and uterine axis. You see the uterine axis itself keep the uterine in position. So what is the nothing but uterine axis? That long axis of uterus is perpendicular with the long axis of the vagina. Okay, thereby it will rest on the urinary bladder. Then fibromuscular structures. So what is this fibromuscular structures? Around the uterus in the pelvis, the parametrium means the connective tissue present between the endopelvic fascia and the pelvic fascia. It is thickened in some areas, or sometimes it is condensed around the vessels, nerves and everything. Whereas around the viscera, they are forming the sphincters, or from the viscera to other walls of the pelvis in the form of ligaments. So this is derived from the parametric tissue. Okay, so that parametric tissue extending from the uterus to the various walls, means either anterior wall, or posterior wall, or lateral walls. So they are extending from the viscera towards the pelvic walls, parietes. So forming ligaments, which are nothing but true ligaments, because these are the condensed structures derived from the connective tissue. Whereas secondary structures are peritoneal folds. They are secondary to all these muscular, visceral, fibromuscular. So secondary means probably these structures are suspending the uterus. Okay, so these are the false ligaments or false folds derived from the peritoneum. Means where from the parietes towards the uterus or from the uterus to the viscera, the peritoneum is folding backwards. So which are known as false or peritoneal folds. They are considered as secondary supports of the uterus. So what is ligament here? So ligament refers to attachment of the uterus. So all the ligaments connecting the uterus are collectively known as ligaments of uterus. So either it is peritoneal fold or fibromuscular fold, whatever it is collectively, the attachments means ligamentous attachments to the uterus, which are classified under peritoneal folds and true ligaments. So what are these peritoneal folds? Broad ligament, pair of broad ligament, utrovesical fold, then rectovaginal folds. The true ligaments are round ligament, lubocervical ligaments, transverse cervical ligament or cardinal ligaments or McEnroth's ligament, then uterosacral ligaments. So what is the function of these ligaments is nothing but hold the uterus in place, then moreover enclose the nerves and vessels and the parts of the uterus. So come to the broad ligaments. So what is this broad ligament? See, the broad ligament is a peritoneal fold. So a double layered structure consisting of a little amount of muscle also. So it is a double layered fold of peritoneum extending from the lateral aspect of the uterus to the lateral pelvic wall and to the floor. So what happened? It presents an upper free border, lower attached border. So the lower border is attached means to the pelvic floor where it is diverging like this, anterior and posterior. Okay, whereas superior border is free means it is enclosing the uterine tube and continues with the anterior layer. Okay, and lateral border is going to attach the lateral pelvic wall. So altogether the shape given to the broad ligament is quadrilateral. So broad ligament is a double layered peritoneal fold consisting of 4 borders. So the shape is quadrilateral. The upper free border is enclosing the uterine tube, whereas lower border is attached to the pelvic floor where it is diverging into anterior and posterior layers. Then lateral border is attached to the lateral pelvic wall. And medial border. So medial border means where it is enclosing the uterus. Means along the lateral border of uterus, what happened? The broad ligament is diverging and enclosing the uterus. So what happened along the lateral border? The uterus is non-peritoneal. Why? Because there is a diversion, means diverging of the broad ligament. Peritoneum is diverged. Okay. So what are the structures? Along the superior border, you see this is pre-superior border. We have a uterine tube. And the superior border means if you place this broad ligament towards the lateral pelvic wall, what happens? It is continuous with the lateral pelvic wall where it is known as suspensory ligament of ovary. Why? Because this part of broad ligament is connecting the ovary with that of lateral pelvic wall and carrying the vessels, nerves towards the ovary. So the neurovascular structures of the ovary present in this suspensory ligament. Suspensory ligament of the ovary. Okay. Then along the medial border we have a tortuous uterine artery. Tortuous uterine artery. And along the inferior border of the broad ligament, what happened? The uterine artery crosses the ureter, then enters into the lateral border of the uterus. Then it has an anterior and posterior surfaces. See, anterior and posterior surfaces. On the posterior means here this is not exactly vertically anterior or vertically posterior. Antero inferior and postero superior. So on the postero superior aspect of the broad ligament, we have a ovary where it is enclosing the ovary and a ligament of the ovary. which is connected to the uterus. So the part of broad ligament between the uterine tube and the ovary, which is known as mesovarium. So what is the structure? The mesovarium. And the part of broad ligament from this ovary and ligament of ovary to the floor, means inferior border. This part is known as, you see, this is the mesometrium. This is the mesometrium and this is mesovarium. Then the part of the uterine tube, see, this is connected to the, means enclosing the uterine tube, the broad ligament, which is known as mesosalpinx. What is that? Mesosalpinx. So here on the antero-inferior aspect of the broad ligament, an important structure we can identify, that is the round ligament. So here if you identify, the three structures gets attached to the uterus at the angle. So one is uterine tube, so in front and below to the uterine tube, round ligament. Below and behind the uterine tube, the ligament of ovary. These are the three structures that gets attached to the corner of the uterus. Okay. So these are the structures are present. So what are these things? Mesosalpinx, mesovarium and mesometrium. These are the nothing but mesenteries. Means the foldings of this broad ligament. And what are the other peritoneal folds? Uterovesical fold. See here, and rectovaginal fold. First you trace the peritoneum from the rectum. If you identify the upper 1/3 of rectum, the peritoneum encloses the anterior surface and lateral surfaces of the rectum, then continues with the lateral pelvic walls. Whereas if you identify the middle third of the rectum, the peritoneum covering only anterior surface of the rectum, then it extends on to the posterior surface of the uterus. If you identify here clearly, it is not directly extending on to the uterus. It is extending on to the posterior cornix of the vagina. That's why instead of giving name recto-uterine pouch, here this fold, recto-uterine fold, we are giving a name recto-vaginal fold. What is that peritoneal fold name given here? Recto-vaginal fold. So extending from the posterior fornix to the rectum. Okay. So this is the peritoneal fold. Thereby it forms a pouch. So what is that? Recto-uterine pouch of Douglas. Then it extends on to the uterus, and from the anterior surface of the body of the uterus, it extends on to the upper surface of the urinary bladder. Because here the peritoneum doesn't extend on to the supravaginal part of the cervix. So here the supravaginal part of the cervix is non-peritoneal. So thereby here it forms a peritoneal fold which is named as rectovesical fold. And by this fold there is a peritoneal pouch is formed. So what is that? Rectovesical pouch. So these are the two peritoneal folds which are supporting the uterus. Then what are the true ligaments? The true ligaments are nothing but condensation of the connective tissue, nothing but parametrium. So the important ligament is the round ligament of uterus. As you know, the round ligament is a remnant of the gubernaculum. So what for this gubernaculum? So by this gubernaculum, the ovary will descend to the pelvis, means in the lateral pelvic wall from the posterior abdominal wall. So by its attachment, so the gubernaculum is attached to the cornua of the uterus. So the round ligament is attached to the cornua of the uterus, just antero-inferior to the uterine tube. And what is the extent of this round ligament? From here it extends towards the deep inguinal limb, through which it enters into the inguinal canal. So finally it gets attached to the connective tissue of the labium majus. Okay, and along this round ligament, it carries the blood vessels and lymphatics from the area which is draining, means the area just junction, means at this uterine tube, drained by the vessels which are accompanying the round ligament. So those vessels are accompanying this round ligament drains into superficial inguinal lymph nodes, lymphatics, whereas the vessels draining means the veins draining into the external iliac vein. Okay, and see, this ligament is consisting of not only this fibrous tissue, it is also consisting of muscle. But the amount of muscle tissue is more compared with the rest of the part close to the corner of the uterus. Then transverse cervical ligaments. See the name given, transverse cervical. It is located transversely, and these ligaments are particularly at the junction between the body and cervix. So the ligaments which are gets attached to the cervix of the uterus. Okay. So transverse cervical ligament is also known as McEnroe's ligament. It is very important structural support, ligamentous support for the uterus. So extends from the lateral margin of the cervix to and upper margin of the vagina to the lateral pelvic walls. And this ligament carries the uterine artery. Then uterosacral ligament extends from the anterior side of the sacrum to the sides of the cervix and uterine body. Means it is at the junction. Okay, so uterosacral ligament. So it supports the uterus from behind. So what are the blood vessels supplying the uterus? See, it's supplied by uterine artery. Most of the uterus is supplied by the uterine artery and partly by this vaginal artery and ovarian artery. See here, uterine artery is an important branch of the anterior division of the internal iliac artery. Okay, along the inferior border of broad ligament passes, then crosses this ureter, then appears along the lateral border. On reaching the lateral border, it divides into anterior and posterior sets and forms the means that's the arcuate arteries. Okay, and from there onwards, it forms the plexus. Similarly, here veins are accompanying this uterine artery and drains into the internal iliac vein. Then close to the means at the lateral corner or angle of the uterus, there is anastomosis. See, the ovarian artery is anastomosis with this uterine artery. And cervix is mainly supplied by the vaginal artery. See, the vaginal artery again is a branch of the anterior division of the internal iliac artery. So these three main arteries are supplying the uterus. The veins are, you see, the veins are just accompanying the arteries, so they drains into internal iliac veins, external iliac vein, ovarian vein. And here you see the here. So whatever veins draining this ovary are forming plexus, pamphiform plexus, and these pamphiform plexus forming the ovarian veins, and these ovarian veins are forming this. Finally, it forms a single ovarian vein. Okay, which accompanies this ovarian artery. So we can identify these structures in the suspensory ligament of the ovary. Then lymphatics. See, the lymphatics mostly they drains into these internal iliac lymph nodes, and those upper part means fundic area and upper part of the body drains into the para-aortic lymph nodes and the pre-aortic lymph nodes. Whereas posterior aspect of the cervix, which drains into the sacral lymph nodes, and the lateral part of the cervix drains into the obturator lymph nodes. Sometimes the paracervical lymph nodes are intercepted and finally drains into this obturator lymph nodes. Okay. What is the nerve supplying the uterus? See, sympathetics are derived from this T10 to L1. So they are supplying the uterus and both cervix and uterus. Okay, and the labor pains are therefore referred to areas of skin supplied by these nerves. Example, lumbosacral region and lower abdomen and loins. Whereas parasympathetic nerves derived from pudendal nerve, S2, S3, S4. And the seed may partly supplied by genitofemoral nerve and the perineal branch of the posterior femoral nerve. So these are the nerves supplying the uterus. Then prolapse. So what is this prolapse? weak or damaged uterine ligaments, mostly the true ligaments and the pelvic muscles, means the levator ani. It leads to a complication known as prolapse. So which involves the uterus falling inside or even through the vagina it gets prolapsed outside. So partially or completely means prolapse, completely means outside the vagina. So this is avoided through the action of pelvic floor muscles and the ligaments of uterus, which keeps always it in anteverted and anti-flexed position. So the normal position of the uterus must be an anteverted and anti-flexed, whereas retroverted position is usually leads to prolapse. So it may be acquired or congenital. Okay. So what is the degrees of uterine prolapse? You see, first degree prolapse wall extends up to the cervix. So only the uterine wall prolapsed into the cervix. In second degree, what happens? It prolapses through the cervix and remains within the vagina. Then third degree prolapse fundus extends outside the vagina. Whereas in fourth degree, you see both vagina and uterus are prolapsed. So these are the various degrees of uterine prolapse you can see. Okay. Then types of vaginal wall prolapse. So vaginal wall prolapse means, you see, if with the anterior vaginal wall prolapse, the prolapse of upper part of the anterior vaginal wall with base of the bladder means here you can identify this is the normal anatomy of the uterus. See, this is the urinary bladder and uterus, and this is vagina. Okay, and identify the anterior vaginal wall is slightly lower than this, means smaller than this posterior wall. Posterior vaginal wall is slightly higher. Okay, so if bladder means the prolapse of this bladder means base of the bladder, it is called cystocele. Here you identify. Whereas prolapse of the lower part of the anterior vaginal wall means with the urethra is called urethrocele. Complete anterior vaginal wall prolapse is called cystourethrosis. Means complete anterior wall is prolapsed. So what is that condition called? Cystourethrosis. Whereas posterior vaginal wall prolapse means enterocele. Enterocele means you see the peritoneal fold between this rectum and uterus. What is that? Recto-uterine pouch of Douglas, into which the small intestine coils may means in normal position also they appear in this pouch. So in case of posterior vaginal wall prolapse, so what indicates the intestinal coils may herniate through this posterior wall. Whereas rectocele means see the rectum will be prolapsed to the lower part of the posterior wall of vagina. So these are the two kinds of posterior vaginal wall prolapse. So in this way, if pelvic muscles or ligaments, not only a single structure, it may be a congenital or acquired due to various reasons. So any weakness of these structures, it leads to prolapse of the pelvic viscera. So various sources are there. It may be through the anterior vagina or posterior vagina, posterior vaginal wall. So accordingly, we can see the prolapse of these various pelvic viscera. So this is about the uterus. So you should learn about these parts of the uterus, and I have not discussed about the structure because it is discussed in the histology. So here I have mentioned gross anatomy. So gross means what are the different parts, what is the normal position. Means if any deviation from normal position means what are the other positions you have to know. And what are the conditions, means what are the causes for this prolapse of the uterus. So for which you should know the detailed structure of the pelvic diaphragm also. Okay, thank you.